I'm here to talk about ACL return to play. A very simple subject, really. The aim is to predict the return to play date for a player at the time of ACL injury. It should really be a simple thing, shouldn't it? The player comes to see you, the only thing they want to know is, "Doc, when can I return to play?" And that's what I'm going to focus on with this. When you answer it, it should be easy. ACL injury, ACL reconstruction, and return to play. But in researching this topic, it's obviously a lot more difficult. Some of the data that I've found have shown that up to 88% of players or patients expect to return to their pre-injury level of sport, when in reality only 65% actually do return to that level. And that's quite a discrepancy. More so, as we've already heard from Jose this morning, in the young active athlete, it's even higher risk. And we can debate if that's due to increased exposure or just the physiology of age. But regardless, it raises the questions. Do players or patients return too soon? When is it safe to return? And can we even say when it's safe to return? So already I've amended this slide. We've gone from having a very straightforward three-piece diagram to introducing the word safe after the ACL reconstruction to the point where we return to play. A quick bit of brainstorming provides these 25 factors that can impact each of these three stages, or indeed more than one stage. And this is far from an extensive list. I'm sure between us all we could come up with many more options or reasons why there is a delayed return to play. So the question I wanted to ask, really as the topic of this talk, is how can we predict the safe return to play following an ACL reconstruction? How can we answer that player in that first consultation, if indeed we can? We're all familiar with return to sport tests. Would they be able to guide us with this? And again, a couple of highlights from researching this topic before the talk. There were some controversial headlines in the literature. Only 23% of patients pass a return to sport battery before returning to sport, which would suggest that many patients actually return to sport without having suitable knee function to do so. That may lend itself to a higher rate of re-rupture, as one might expect. And that's supported in the literature with those who pass a return to sport criteria, reducing their graft re-rupture rate by 60%. However, as we've highlighted again this morning, it actually increases the contralateral ACL tear by what's been described as 235%, which is an outstanding number, but the relative risk of 3.35. Then that begs the question, when, what, and how? When do we do the tests? Which tests do we do? And how many do we do? We're all familiar with muscle strength testing, a variety of different types of hop testing, different movement quality assessment tests, not to mention the psychological tests that we can perform as well. There's lots of different rehabilitation approaches depending on different philosophies and different physios, and all that lends itself to different times of testing. Tests at 6 months will differ to 9 months to 12 months. And also we have to remember, if we're expecting a player or a patient to pass every test that we expose them to, that will by nature decrease the number of patients who are able to pass all the tests at once. We like scores in orthopedics, don't we, to measure outcome measures? Do they help? Well, this is a study we did in collaboration with the Football Association in England a while ago, and we looked back at many years' worth of ACL reported outcomes in the literature. These were the 5 most frequent scores that we used in the literature. We're probably familiar with all of them. But when we look at them in more detail, we were able to identify that it's possible to get a maximum score without a return to play that's quite high in comparison to the maximum score for each scoring system. Indeed, in one of them, as highlighted, you can actually get full marks without actually returning to play. So in summary from our findings, we showed that the mean age of the score was over 30 years, and because we did this a few years ago, The most recent of these commonest 5 scores was well over 20 years. Collectively, almost half of the questions within these scores were related to sport, and almost 1 in 5 specific to sport. But in spite of that, it was still possible to achieve an outcome score of 100% in one of them, and at least 90% in all of them post-ACL reconstruction, but not actually have a return to sport. So we concluded that the majority of the literature describing outcomes from ACL surgery actually doesn't convey the relevance, particularly to elite athletes, when they want to return to sport. So if scores don't work, it's 2022, what about the role of AI, artificial intelligence? Computers, after all, are everywhere, aren't they? Well, a study we did with Wolverhampton Wanderers, an English Premier League football club, looked into this. Now, I'm sure when everyone first looks at this slide, it needs no explanation at all. Although, joking aside, if you're looking at it like I did the first time, you probably don't understand what it means. This is the equation that we used. It effectively was the equation we dialed into the computer to try and predict the return to play time following an injury for our players. This is what it came out with. Now, just to explain, the x-axis is the days unavailable, and the y-axis is the error that the machine learning model, the artificial intelligence, predicted. So if I highlight this cluster in the bottom left of the graph, we see all the injuries that took less than 25 days to return to play. Not a single one of them had an error in the prediction of more than a day and a half. If you look at the top right of the graph, you see that varies a bit. There was more error with the longer term injuries, more akin to an ACL reconstruction return to play. But it was a very linear prediction. It was quite consistent. Again, in the bottom left, here we see the x-axis of the prediction and the y-axis of the actual days unavailable. And the darker the blue colour, the more accurate that prediction. The more red the colour, the less accurate the prediction. For those who like the numbers, these were the root mean square error, the mean absolute error, and the mean relative error. But in essence, what this all means is that our model meant that an injury with a return to play of less than 14 days was accurately predicted to within 1 day of error from our artificial intelligence model. That degree of error increased with return to play time. Therefore, we can say the more significant the injury, the less accurate the prediction. However, it was always accurate to 7%, which means that that would mean a 2-week error in a return to play time of 7 months and a 3-week error in a return to play time of 10.5 months, more like what we'd expect with an ACL reconstruction. How does that match with the expectations of the player? Well, we looked at that too. We've looked at expectations in a cohort of around 50 professional footballers who suffered ACL reconstruction. And the reason we did this is because we sit in our office and we hear, well, player X returned in 6 months, why can't I? My coach says I'll be back in 6 months, why won't I be? And the other surgeon I saw said I'll be back sooner than you did, why won't you? And this is why. So we looked at there's almost 50 patients, and the median return to play was 8 months for these players. When you look at the general public expectation and the expectation in the media, it's driven, and it caused 6 months to be the median finding there. The other thing that we showed is that a shorter return to play meant a higher rate of recurrence, again consistent with the literature. So again, we're not really meeting our expectations to return to play, but then we can ask the question, is returning to play enough? Should we actually be thinking about returning to performance? When do you get back to playing at the level that you want to play at? And we did this study in collaboration with Blackpool Football Club, a championship level football club in the United Kingdom. Effectively, we came up with a scoring system to try and evaluate pre-injury performance and post-injury performance once there was a return to play. This was a points-based system, and it did not include the time period that a player was unavailable to return to play. Effectively, this is what we saw pre-injury and post-injury. The range of points was very similar, but the total score, the mean score, and the median score were all notably less in the post-injury group. That wasn't to say everyone did worse. 18 players actually did better with their return to play scores after the ACL reconstruction. 25, though, did worse, more did worse. And interestingly, one did exactly the same. This was the breakdown per player. And as you can see, it's all over the place. And that's because there weren't any really predictive factors that we could utilize to suggest which players did better afterwards, which players did not, other than age. Seemingly, players who were under 21 did better after the return to play than players over the age of 22. That may, however, have been due to our methodology. Finally, is there too many variables? Remember this slide? Well, there's already loads of variables there, and that wasn't even half of them. But can we control some of them? Can we control the variables that can be controlled? And if people aren't familiar with this work, I'd strongly recommend accessing the British Journal of Sports Medicine, Open Access, and Matt Taberner's work on the chaos control continuum. I had the pleasure of working with Matt at Everton Football Club once upon a time, and he, in his PhD, came up with this theory of progressive incorporation of greater perceptual and reactive neurocognitive challenges as a framework moving from high control to high chaos in a player's rehabilitation. It was based on his experience in the English Premier League. This is a busy slide, but it somewhat describes what we're trying to achieve. High control, everything that we can control in early rehabilitation, through to high chaos, as close as we can get to the chaotic environment of a game situation. And it's worth having a read in closer detail of that. So will we get better in the future? Well, lots of people are trying to produce an answer. We were trying here at the Boston conference a couple of months ago. There are consensus groups, data is constantly presented and published, and we discuss it at meetings, like at Boston and even here today as well in Egger. But none of that allows for the individualized nature of ACL injury. One size will never fit all, and we still need a bespoke arrangement and approach to our individualized patients and their needs. So in summary, Mr. Chairman, ladies and gentlemen, how can we predict the safe return to play following an ACL reconstruction? I'm not going to say we can't, but it certainly is difficult. And there's no single answer because, let's be honest, it's never going to be 100% safe to return to play. And that leads us to scope for future development. Maybe somehow if we can combine and incorporate all of updated modern scores, clinical findings, physical functional performance, psychological assessment, and maybe even artificial intelligence, we can come up with a model that recreates this and is better able to predict a safer return to play for our players and patients. So all that's left for me is to say thank you on behalf of Boston once again, and to remind everybody sustainability is important, and let's save the turtle. Thanks very much.